Thank you for joining Cancer Support Community Atlanta for Hereditary Cancer Syndromes in Men, facilitated by Shrutika Yeola with Northside Hospital Cancer Institute. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs.
Hello, everyone. Thank you for joining us today. This is Emily Brown, the Program Director at Cancer Support Community Atlanta. So you know you are going to be muted throughout the program, but if you do have a question, you can submit that at the chat box on the bottom of your screen, or if you're on your phone, there should be 3 dots for settings, and you can submit to the chat there. And we will address those questions at the end of the program. Shrutika Yeola is a genetic counselor with Northside Hospital Cancer Institute, and she does these regular genetic counseling seminars for us. We've been doing them bi-monthly since the social isolation. But this month we decided to focus on men's genetics, so I'm very excited to be providing this program to you all, and I hope you enjoy it. So without further ado, Shrutika, you can go ahead and get started.
Again, my name is Shrutika. I'm one of the genetic counselors at Northside. We are a group of 6 genetic counselors. Right now, we just hired our newest GC who started just a few weeks ago. So really excited for all of you to be joining me today via the virtual platform. If any of you have attended any of our previous talks, some of this information may be a review to you, but this time I decided I really wanted to focus on those hereditary cancer syndromes and how they affect men. I will be going through some of the more common hereditary cancer syndromes that we talk about in clinic on a daily basis, and specifically how they affect males, what kind of screening is required, what kind of surgery management is recommended for male individuals who have one of these hereditary cancer syndromes. So really excited to be part of this talk with you today. Let's get started. So, from the very beginning, I just like to go through genes and cancer and background information on what this is all about. You may have heard that all cancer is genetic, but not all cancer is necessarily hereditary. So what exactly do I mean by that? In order to kind of break that down a little bit further, let's take a step back all the way to high school biology. Our bodies are made up of billions and billions of cells. Within our cells, we have a nucleus, so kind of think of that like the brain of the cell. Within that nucleus, we have chromosomes, 23 pairs of them, 23 from mom, 23 from dad. And I kind of like to think of these chromosomes like recipe books. They house instructions for our body, tells our body how to grow, how to develop, make us unique. Now, if you were to stretch out one of these chromosomes and break it up into individual pieces, those are the gene, which for the purposes of this analogy, you can think of like a recipe. And that gene codes for a protein, and that protein is ultimately what goes around in the body and does very specific jobs, very specific roles. Some of these genes are responsible for protecting us from developing cancer. They work to fix these random mistakes that build up over the course of our lifetime that ultimately can result in a cancer developing later down the road. So I kind of like to think of these genes like spell checkers. And just like all the other genes in our body, we get 2 versions of that gene, one from our mother, one from our father. So for a lot of these hereditary cancer syndromes, they do affect both men and women. But if one of these spell checker genes, one of these genes that's responsible for protecting us from developing cancer, is spelled wrong itself, it can't do its job the way it's supposed to. And that's when we see a stronger family history of cancer, or a variety of different patterns in an individual that they were, or in an individual or a family, that makes us realize that, this is more than just random chance. Maybe there's something being passed down from generation to generation that's causing that increased risk. So cancer is genetic, meaning it is a buildup of genetic abnormalities acquired over the course of our lifetime, but it's the hereditary piece, the broken gene that you were born with, that only accounts for a small portion of all individuals who have cancer in themselves or in their family. So I think this breaks it down a little bit more. When I break down cancer, I do break it up into 3 categories: sporadic, familial, and hereditary. So we've already touched a little bit on sporadic and hereditary. Sporadic, again, meaning that random occurrence, the ones that happen just by chance, the reason that all women need to get mammograms, all men get their prostates checked, why both men and women have to get their colonoscopies starting at age 50, et cetera, why we're all supposed to go to the dermatologist. I'm really bad about it, but it's something we all need to do because we all have that baseline risk. Hereditary, again, is that gene that's broken, that's being passed down from generation to generation, causing that increased risk. This familial category, that red portion of the pie, also is something to be mindful of. There are a lot of families who come in to see a genetic counselor or who have an evaluation for hereditary cancer, but we do all the genetic testing in the world and we don't find anything. Well, there still might be a family history that makes us suspicious of something hereditary, something inherited. And even though we didn't find anything through genetic testing, there could still be something there that is being passed down. Our technology just doesn't allow us to detect it. So I always like to remind people that even if you do genetic testing and you find out, there is no inherited cancer syndrome in my family, that doesn't take away from the fact that there is a family history there that you have to be mindful of. Make sure that you're getting your screens, make sure you're being aware of that family history, make sure you're sharing that information with other family members so that you all can be as proactive about your health as possible. This is another way to kind of differentiate between hereditary versus sporadic cancer. So remember, sporadic cancer, those random cancers, are a buildup of mistakes within our DNA. Cells in our body are constantly dividing, constantly turning over, creating fresh copies of themselves. And when that happens, those recipe books that I was talking about, that DNA, has to transcribe itself exactly. And it's pretty remarkable that our bodies are able to do this over and over and over again. But every once in a while, as you can see in that first row, a mistake will happen. In the world of genetics, we call mistakes mutations. So one mistake happens. All right, one mistake, not that big of a deal, isn't going to result in cancer. But then those cells divide, and over time, another mistake happens. Now, those 2 copies of that gene, the one that that person got from both mom and dad, now both have mutations. And now that they both have mutations, now they look abnormal. Now maybe cells will grow out of control because they're no longer following the normal rules and regulations of cell growth and division. That's sporadic cancer, those mutations that are acquired randomly over the course of our lifetime. However, in hereditary cancer, as you can see, those individuals start one step ahead of everybody else. One gene is already broken, already has a mutation from birth. That mutation was inherited from one of their parents. And so it doesn't take as much for that other copy to eventually be broken as well, and thereby result in an increased risk to develop cancer, or cancer at a younger age, or more cancer in the family. So when an individual comes in to see a genetic counselor, we're looking for those patterns, for those clues that might make us suspicious of something inherited. We do this by taking a family history. We literally draw out every member of a family, draw out a family tree so that we have a visual of what's going on. And we're looking for very specific things. How or who's been diagnosed with cancer? What kind of cancer? How old were they when they were diagnosed? Do I see more on one side of the family or the other? Do the diagnoses that I see go together with specific syndromes? Age of onset, if somebody's diagnosed under the age of 50, that's going to make me a little bit more suspicious than a diagnosis over the age of 50. Because you may have heard that cancer oftentimes is a disease of aging. The more time there is for those mistakes to build up, the more likely a cancer may form. But if that diagnosis happens at a much younger age, then could there be more than just that random chance? If there are multiple generations affected, that's important to keep in mind. If somebody in a family has several types of cancers associated with the same genetic syndrome, that's going to make us suspicious. So I use the example of breast and prostate cancer because both of those cancer types can oftentimes go together with actually a wide variety of different inherited cancer syndromes. If multiple close family members have the same type of cancer, that's going to be striking to me. Somebody with different types of cancer, or they get cancer more than once, that's also, unusual. We typically don't see somebody develop more than one cancer over the course of their lifetime. So that's going to raise a red flag. And then we always ask about ancestry. We do know that certain populations have an increased prevalence of certain genetic mutations. And so there is an aspect there that we need to be mindful of. For example, individuals of Ashkenazi Jewish ancestry, both men and women, have a 1 in 40 chance of coming back positive for specific mutations in the Bracha genes, which some of you may have heard of before. And so that's always something that we're taking into account when thinking about whether or not we're suspicious of something hereditary or not. So that segues perfectly into the Bracha genes. There's BRCA1 and there's BRCA2. They serve as two of those spell checkers that I keep referring back to. They work together in a very specific DNA repair pathway. So you can imagine that they're really, really important. Now, their names are kind of sexist. They're called breast cancer genes, breast cancer 1 and breast cancer 2. So maybe you're thinking, okay, these are only genes that affect women. Well, obviously, as you can probably guess, they affect both men and women. So I do like to start by saying that both males and females carry these genes. Remember, we all have 2 copies of each of these genes, one from our mother, one from our father. We're looking to see if there is a mutation or a spelling mistake in one of those genes that causes a person to have an increased risk to develop cancer. Oftentimes, when we talk about the Bracha genes, we hear it in the context of hereditary breast and ovarian cancer, because that's actually the name of the syndrome, hereditary breast and ovarian cancer. So then why are we talking about it for men? Well, obviously, Bracha mutations affect males as well. And so I've listed a couple of those syndromes here, or some of those cancers here: male breast cancer, prostate cancer, pancreatic cancer, and melanoma. Men who are BRCA positive, particularly BRCA2 versus BRCA1, have up to a 7% lifetime risk to develop breast cancer. General population risk to get male breast cancer is about 0.7%. So it's quite dramatically increased if somebody is BRCA2 positive. And so for that reason, we recommend clinical breast exams starting at age 35 for all individuals who, or for all males who are BRCA positive, starting again at age 35. Prostate cancer, also a big cancer that we see increased in individuals who are BRCA2 positive or BRCA1 positive as well. That risk is anywhere from 20 to 40% as compared to the general population risk of about 13%. That's quite a big jump. And so we do recommend prostate cancer screenings around age 45. Typically, that's a PSA, blood serum test, in addition to a digital rectal exam. And those options should be discussed with the physician to figure out what's going to be the right approach for you. Some families with a BRCA mutation also have an increased risk to develop pancreatic cancer. That risk is not, dramatic, maybe compared to that prostate cancer risk, but it's still something to be aware of. There can be personalized screening based on the family history, including endoscopic ultrasounds, MRIs, and other types of screens to kind of address those pancreatic cancer risks for those families where it's applicable. And then melanoma as well, that risk is slightly increased. But again, we should all go to the dermatologist anyways. So screening for that particular cancer doesn't change too much, knowing that you're BRCA positive. Obviously, the pancreatic cancer and the melanoma are cancers that affect females in addition to men, but this is something important to be mindful of, and how your knowledge of what your BRCA status is very, very important in addition to the females in the family. I just wanted to point out a couple of support networks or information awareness groups that are out there specifically dedicated to males with breast cancer or men who are BRCA positive. The one on the bottom, FORCE, Facing Our Risk of Cancer Empowered, is a big organization dedicated to people, both men and women, who are BRCA positive as well as positive for other hereditary cancer syndromes. They have a lot of really great information on their website, a lot of information on screening, also the support network stuff. They also have an annual conference that patients and clinicians can attend. So it's definitely a good resource to look into if it's something that's important to you. And then this other organization, HIS, Breast Cancer Awareness, they also have a lot of interesting information and support network information for men who have breast cancer. There isn't a lot of information for men about breast cancer out there. And so this brother and sister duo created this organization to help bring awareness to those, the guys who also need this information just as much as the women do. So beyond the BRCA genes, there are several other hereditary cancer syndromes as well, but another one that we talk about a lot in our clinic is something called Lynch syndrome. It's also called hereditary non-polyposis colorectal cancer syndrome, or HNPC, but most people these days call it Lynch syndrome. Lynch syndrome is caused by mutations in a set of genes called our mismatch repair genes. So similarly to the BRCA genes, they function to fix errors in our DNA. Specifically, they fix mismatches. That's why they're called mismatch repair genes. There's 5 of them, which are listed here. And a mutation in one copy of any one of those genes causes an increased risk to develop certain types of cancer. Namely, it's the most common inherited form of colorectal cancer, but it can also be associated with other cancers along the GI tract. I mentioned here that Lynch syndrome is a dominant condition, and I'll quickly explain what that is. The BRCA genes are also a dominant condition, as are most hereditary cancer syndromes. So remember, we all have 2 copies of each of those genes. We're going to go through that over and over and over again. It only takes one broken copy of one of those genes to have that increased risk to develop cancer. So if you inherit a mutation from your mother or you inherit a mutation from your father, it doesn't matter. If you have that mutation, you have those increased risks. If you're a guy and you inherit it from your mother, it's the same thing. If you're a female and you inherit it from your father, same thing. As long as you have that broken copy, you have that increased risk to develop cancer. So for Lynch syndrome, I liked this diagram because it really kind of demonstrates the wide variety of different cancers that somebody with Lynch syndrome could potentially develop. The most important one, again, is colon cancer, but we can see cancers of the upper GI tract as well, stomach cancer, pancreatic cancer, cancer of the urinary tract. There are some rarer cancers as well, including small bowel cancer, hepatobiliary tract cancer. In men, prostate cancer, and then in men and women, brain cancer, and then these skin findings called sebaceous adenomas or sebaceous neoplasm. Typically, they're fairly benign. They don't really spread, but it's something to be aware of. In women, beyond all of those cancers, we could also see an increased risk for ovarian and uterine cancer. And it's important to note that 1 in 300 people in the US potentially have Lynch syndrome, which in the world of genetics is high. Oftentimes in genetics, we're talking about super, super rare conditions where it's 1 in 10,000, 1 in 20,000, and even rarer. To see 1 in 300 people with Lynch syndrome is fairly common. The Bracha genes, as a reference, is fairly common as well. 1 in about 400 individuals have a mutation in the Bracha genes within the US. So just to summarize some of the Lynch syndrome management recommendations, our National Comprehensive Cancer Network, or NCCN, recommends colonoscopies, obviously, given that colon cancer is that most prominent, most prevalent cancer risk that we see. Colonoscopies every 1 to 2 years, starting at age 25. Upper GI screening, depending on family history, usually that would be an upper endoscopy. Maybe that means other types of upper GI cancer screening, depending again on family history and what's pertinent to that individual. Earlier, increased prostate cancer screening. I put that in question mark with a question mark just because at this point in time, NCCN doesn't have specific recommendations or guidelines for men who have Lynch syndrome in regards to prostate cancer. Some of those Lynch syndrome genes that I've listed here have a higher risk or harbor a higher risk to develop prostate cancer than the others, but it's still something that we're trying to learn, trying to develop that data to help determine which men who have Lynch syndrome need that increased prostate screening over the general population. So again, I do like to just remind individuals that your family history very much matters. A lot of hereditary cancer is something that's still developing, that we're still trying to learn. And oftentimes your family history is still going to be the most powerful tool to use in order to determine what those next steps are for you and your family. And then of course, uterine and ovarian cancer surveillance or surgery for females. Beyond the Lynch syndrome genes, beyond the Bracha genes, there are even more hereditary cancer syndromes out there. This is not even an exhausted list, but there's Li-Fraumeni, hereditary diffuse gastric cancer, Cowden syndrome, familial adenomatous polyposis, and many, many more. In 2020, we know more than 80 different genes associated with inherited cancer. The syndromes that I've listed here are some of the most well-established or high-risk cancer syndromes out there that we oftentimes talk about, but these are also some of the rarer types of hereditary cancer syndromes out there. A lot of these genes are associated with breast cancer, so oftentimes you'll see them on a breast cancer panel. And when I say breast cancer, I'm specifically referring to female breast cancer. But each one of those genes is also associated with cancers in males as well. And so I order breast cancer panels on men all the time because of the implications that it has for their family history based on, or for themselves based on what I see in the family history. So I specifically wanted to pull out prostate cancer since prostate cancer is one of the most common types of cancer that a male can develop over the course of his lifetime. Lifetime risk for the general population is about 13%. But we're doing more and more research. Every year we're learning more about the hereditary contribution to prostate cancer. I got these charts or these graphs from one of the genetic testing labs that we use in our clinic. Their name is Ambry Genetics. They're one of many labs that we use, just to kind of show the prevalence of mutations or the prevalence of a hereditary cancer syndrome in those individuals who receive testing for hereditary prostate cancer. So Ambry has a very specific test called Prostate Next. So it includes several genes that we know in 2020 are associated with inherited prostate cancer. And 15% of individuals come back positive, meaning, yes, we found an inherited mutation in that person that could cause his risk to develop prostate cancer to be higher than average. You can see from the bar graph that BRCA2 is the most common mutation that we do find, followed by a gene called ATM, which is a moderate risk gene, again, associated with female breast cancer, but that could also be associated with prostate cancer. HOXB13 is a close third, and that is a gene associated exclusively with prostate cancer at this point in time. So definitely something worth keeping in mind. Most people, again, come back negative, meaning normal, because most cancer is sporadic. There is a category of result called a VUS, or a variant of uncertain significance, meaning that we found a variation in one of the genes, but we don't know what it means because we're all a little bit unique. VUSs happen. We treat them like negatives, so that's what that category is. But again, it's very striking to me that 15% of people who undergo testing for this prostate cancer specific panel come back positive for something. And this ties in with another study that was done back in 2016, or that was published back in 2016, specifically about metastatic prostate cancer and hereditary cancer syndromes. One of the things that we've noticed in the world of cancer genetics, specifically prostate cancer, is that people who have one of these inherited cancer syndromes tend to have more aggressive prostate cancer, ones that are more likely to be metastatic, ones that might require more aggressive treatment if they come back positive or if they have that cancer. And this study is one of those things that kind of prompted that. So almost 12% of men with metastatic prostate cancer have a germline mutation, germline meaning that they inherited that mutation in one of those DNA repair genes. So again, one of those genes that normally is supposed to protect us from developing cancer, but if it's broken, it's not doing that, regardless of family history. So it doesn't matter what your family history looks like. If you have aggressive prostate cancer, now our guidelines do say you benefit from genetic testing, not only to help identify maybe why you developed your prostate cancer, not only to help your own cancer treatment, but also to help your family. When it comes to cancer treatment, we do have specific chemotherapies nowadays that can target or can be personalized to an individual who has prostate cancer based on their genetic mutation, because that particular chemotherapy is targeting the pathway that's abnormal because of that inherited mutation. And so it definitely has that treatment implication as well, which is why it is really important that men who have prostate cancer consider genetic testing, because it could help in a wide variety of different ways. Okay, so we've talked a lot about Lynch, we've talked a lot about Bracha, we've talked specifically in the realms of prostate cancer. So ultimately, who should have genetic testing? And I've listed some of the things that we look out here on the family history, but these are also the things that would warrant a referral to our clinic. A personal history of early onset cancer. So again, I mentioned that that's under the age of 50. A personal history of multiple primary cancers. So more than one type of cancer over the course of your lifetime. A personal history of prostate cancer that is metastatic, again, spread to other parts of the body, or has a Gleason score of at least 7. So Gleason score is a pathological way to measure how aggressive a prostate cancer might be and helps drive treatment or the course of treatment for that individual. That score is anywhere from 0 to 10. a Gleason score of 7 or higher is enough of a red flag for us to take a closer look at that person's personal and family history. If a person has had more than 10 colon polyps, that's also striking to us. There are a lot of hereditary cancer syndromes that are associated with many, many colon polyps over the course of that person's lifetime, which ultimately results in a relatively high risk to develop colon cancer. And so that's a reason to want to come see a genetic counselor. And then overall, strong family history of cancer on either side of the family. Once again, both the maternal and the paternal sides matter. Even a family history of a cancer that you don't see in males or a family history of cancer that you don't see in females could warrant genetic testing for the person of the opposite gender, opposite sex, because of the wide variety of different cancer types that we might see in somebody who has one of these cancer syndromes. So ultimately, you come in through the door, you're referred by your doctor to come see me so that you can talk about your family history and your genetic testing options. When somebody comes in to see a genetic counselor, we don't automatically force them to do genetic testing because there are pros and there are cons. And so I've listed them out here, but these are things to think about when it comes to doing genetic testing and your motivations for testing and what you're hoping to do with this information, because that is just as important as the rest of it. So some of the benefits: a positive test result provides the person an opportunity to understand and in some cases manage their cancer risks. So we talked about Bracha and Lynch and some of those very specific screening management protocols that are in place for individuals with that condition. That ties into how these results may help in making decisions about cancer treatment. So I started to touch on metastatic prostate cancer and coming back Bracha positive, and how if somebody is Bracha positive, they may be recommended to get a very specific type of chemotherapy because of that mutation and the pathway that it's part of. Of course, genetic testing doesn't just affect the person sitting in front of me in that session, but also affects the rest of the family members as well. And so it empowers not you to share this information with everybody else. And then in the instance where we already know that there's a genetic mutation in the family, genetic testing and coming back negative can provide that person with that peace of mind that they didn't inherit that cancer syndrome and that their lifetime risk to get cancer is the same as the general population risk. Naturally, there are some limitations to genetic testing as well. A lot of this gets touchy-feely, but it's very important to be mindful of as well. Psychological stress of learning that you have a higher risk to develop cancer is something to be thinking about. Are you ready to know this information? And then on top of that, trying to determine how you're going to share this with your family members, with your kids who may be not ready to know this information or resistant to knowing this information or resistant to going to the doctor. How are you going to share this important information with them? We talked a little bit about those uninformative test results, those variants of uncertain significance. I can definitely see that even though we treat them like negatives, that uncertainty there could increase stress. Survival guilt upon learning that one doesn't have a harmful variant that is present in other members of the family, particularly with some of these higher risk syndromes that warrant a lot of extra screening or are associated with high risk to get fairly aggressive cancers. I've definitely met several families where those individuals have expressed to me their guilt that they came back negative when the rest of the family has that mutation and are going through so much. So something to think about. Cost of testing, additional follow-up testing if not covered by insurance, certainly a limitation, but I will note that genetic testing is much, much, much cheaper than it used to be. And so it's very affordable for most people. In fact, the folks who come in to see us in our clinic usually don't pay more than $100 for genetic testing. And of course, there's privacy and discrimination issues to address as well. And we'll touch on that a little bit later in this talk. Okay, so besides me, what about my family? What does it mean for them? How are these things inherited? Once again, 2 copies of each of our genes. We only need 1 broken copy to have that increased risk to develop cancer. For my family, when I have each of my kids, I either pass down 1 copy or the other. There's a 50-50 chance that if I'm positive for a mutation, then each of my children could also carry that mutation. So in this little infograph, the father has that mutation. Mother is negative. She has no mutations. Both copy of whatever gene we're talking about is working just fine. So she only has working copies to pass down, but in this case, dad has a 50-50 chance of passing down his mutation. And again, it doesn't matter if it's male or female, those risks are the same. So I want to take a step back and talk a little bit about some of the history on cancer and genetics, and just to demonstrate how things have evolved since the onset of the availability of genetic testing. So one of the biggest things that happened in 2013 is that the US Supreme Court ruled that you cannot patent genes. Up until this point, one lab, Myriad Genetics, had a patent on the Bracha genes. And so they were the only people doing genetic testing. And so they were the people who dictated essentially how to run this test, who should get testing, and insurance companies fed into that. And so I bring this up because at that time, it was really hard for men to get genetic testing covered by insurance because the guidelines in place were very female focused. But since this US Supreme Court ruling, once Myriad lost their patent, all of these other labs that were already doing genetic testing for other things were able to now do Bracha testing. And with that comes competition, and with that comes a drop in prices, and with that comes the availability to do research and to learn more about how these genes affect females and males, and insurance companies get on board. And so our testing guidelines have definitely become a lot broader. And obviously, as you know from the beginning of this talk, a lot of these genes aren't female specific. They're associated with cancers in men as well. And nowadays, it's much, much easier for a guy to get genetic testing and for insurance to cover that genetic testing, because they've now realized how important it is for not only females, but also males. And with more competition comes new testing options. We already talked about how the cost of genetic testing is dropping. And I mentioned, there's more than 80 different genes associated with hereditary cancer that we know of in 2020. And because our technology has gotten better, we're able to test for all of those genes all at the same time, which is pretty remarkable. Of course, with that comes slightly longer turnaround times, a higher chance of those inconclusive test results. But on the flip side, we get a better chance of maybe finding that answer for why there's cancer in the family. But again, pros and cons to all of this, which is why we have a genetic counseling appointment to walk through those pros and cons, because more genes doesn't necessarily mean a better test in all instances. All right. So a couple of common misconceptions. We started to touch on a lot of these already, but I wanted to just drive home the point a little bit more. The cancer history on my maternal or paternal side is the only history that counts. You'd be surprised about the number of times that a physician might mention that to their patient, but as you now know, these dominant conditions are not gender specific. Both mom's side and dad's side count when it comes to assessing hereditary cancer risk. I'm all done with my cancer treatment, so genetic testing doesn't matter to me anymore. Well, sure, when you're doing cancer treatment, having genetic testing can help dictate the type of surgery you might get, or we talked about the chemotherapy options. But once cancer treatment's all said and done, if somebody has one of these hereditary cancer syndromes, maybe their risk for another cancer is also higher. And that's something we need to be mindful of. We need to make sure that that person's getting those screens as well. And then, of course, the family. Even though I've already had cancer, this might affect somebody else. And it's always best, actually, to test the person with the cancer first. Because the question we're trying to answer with all of this is, why is there cancer in my family? Well, let's test the person who's most likely to come back positive first so that we can subsequently confirm and rule out that risk in everybody else. I tested negative, but my kids still need testing because I heard these genes can skip generations. So, as you know, dominant conditions, you have to pass on one copy or the other. So if you have a mutation, there's a 50-50 chance that that mutation could be passed down to future generations. But if you only have working copies, both genes are spelled correctly, what you don't have, you can't pass down. So in that sense, no, genes cannot skip generations. You might seem like a gene is skipping generations because when we're talking about hereditary cancer syndromes, we're talking about risks, not guarantees to develop cancer. And so you might see an entire generation of individuals who don't develop anything, even though they carry that genetic condition, even though they carry that mutation. But that's, again, not necessarily because they don't have that gene or that gene mutation, I should say, but more so just they never developed the cancer that's associated with that mutation. I can't have testing because I'm sure my insurance won't cover it. I can't have testing because if I test positive, I will lose my insurance. So once again, not true. First off, insurance is very good about covering genetic testing these days. Their policies in place are much, much better than they used to be. And so our ability to get testing covered for an individual is much, much better than it used to be. If insurance doesn't cover the genetic testing for whatever reason, maybe that family history just isn't suspicious, or maybe they just don't quite meet the criteria in order for that person to get testing covered. The cash price for genetic testing through some of these labs is $250. So much, much cheaper than it used to be. And so, you know, still a good chunk of change, but much more affordable for an individual to pay out of pocket. And then the part about I can't have testing because I will test positive if I test positive, I will lose my insurance. Well, we actually have laws in place to protect somebody from being discriminated against when it comes to their health insurance and employers. So a health insurance company cannot drop you from their policy. They can't raise your rates. They can't deny you services or coverage based on your genetic information. In other words, they cannot consider your genetic information to be a pre-existing condition. Employers can't fire you from your job. They can't not hire you. They can't put you into specific roles or jobs or promote you specifically because of your genetic information. All of these laws, all of these rules fall under the Genetic Information Non-Discrimination Act, which was passed back in 2008. Now, I will note that this GINA law does not apply to life insurance, disability insurance, or long-term care insurance. So these are things to be mindful of. I don't know that a life insurance will or won't use your genetic information to determine whether or not they're going to give you a good rate on a policy or, you know, insure you at all. But these are certainly things to ask, certainly things to shop around for, things to think about even before doing genetic testing. Another common misconception: I had Oncotype or Caris or Foundation 1 testing. So I already had genetic testing. So these tests are genetic tests on the tumor to help guide treatment. These tests, however, are very different from the type of genetic testing that we offer in our clinic. It breaks down into this type of testing called somatic genetic testing versus germline genetic testing. So somatic testing is testing that tumor, testing for those mutations that were acquired over the course of that person's lifetime, that arose over time, and could help guide treatment to know, okay, this cancer formed because of this abnormal pathway. We have a chemotherapy that targets that pathway. Okay, that's what we're going to prescribe to that patient. But these mutations were acquired. They were not something that that person was born with. Germline testing, that's what we do, is looking at the hereditary contribution to disease. It's testing all of the cells of the body, not just the tumor, looking for those genetic changes that were inherited from the generation above you. And yes, it can sometimes guide treatment, but it also helps determine future cancer risk and risk for family members. I will also note that somatic genetic testing may or may not pick up the mutation that you were born with. Tumors do all sorts of weird, funky things. And so that tumor genetic testing isn't always the end-all be-all for what this could mean for an individual moving forward after that cancer treatment is said and done. So put a little star next to what we specifically focus on in our clinic. And then finally, I had 23andMe, Ancestry.com, or some other direct-to-consumer genetic test, so I don't need to have genetic testing again. If you were at my talk 2 months ago, you know that direct-to-consumer genetic testing is very limited in what it's able to tell a person and the ability of an individual to use that information for their medical management or for their health care. Direct-to-consumer testing, so the ones that you get to order at Target yourself and spit into and ship off without the assistance of a healthcare provider, is not a comprehensive look at the genes. It's not looking at the same kind of stuff that a clinical genetic testing lab is looking at. And this little blurb from 23andMe themselves, that this test is not a substitute for visits to a healthcare professional for recommended screenings or follow-up, is very important to keep in mind. And any result that you potentially get from a direct-to-consumer genetic test should be confirmed using a clinical genetic testing lab that is validated, that is very much focused on looking for these specific mutations that 23andMe, Ancestry.com, et cetera, wouldn't be able to pick up. And so that brings me to the end of the talk. I hope that this was helpful to you. If you have any questions, I always encourage you to talk to a genetic counselor. You're more than welcome to reach out to me or anybody else at Northside Cancer Genetics, or you can reach out to any of the genetic counselors across the country. I've showed you here the National Society of Genetic Counselors website. They have a find a genetic counselor tab that you can click on to find a GC in your area who could help you navigate all of this information personalized to you and your family. And that's all I've got for you today. I've listed all of our genetic counselors here, and I lied. I said there were 6 genetic counselors, but there are 7. I apparently can't talk or can't count anymore, but everybody's listed here for any questions or concerns, or if you're interested in coming to see us, our information is at the bottom. So thank you so much.
Thank you, Shrutika. That was a wonderful presentation. And like she said, although this was great information, it should not replace sitting down with a genetic counselor or in talking to your doctor about any concerns that you have. So definitely write that referral number on the bottom of the screen down if you have any further questions. We did have one question come through, and I'm trying to remember what slide it was that she was referring to. She said, why do you call them syndromes?
Yeah, so syndromes we use to kind of describe a disease or condition that's associated with a multitude of different clinical features. So in classic genetics, somebody who has one of these syndromes may have heart issues. They might have intellectual disability. They might have seizures. They might have lung issues. They might have eye issues, a whole bunch of seemingly unrelated things that's all associated with the same genetic mutation. Similarly, in cancer genetics, if somebody has a Bracha mutation, it's not just one cancer type that they're at an increased risk for, but a whole variety of different cancers as well. Some of these syndromes could also be associated with more than just cancer risk. Some of those clinical features that I just mentioned in regards to kind of more classic genetics, but that syndrome helps to kind of define the fact that there is a lot of variability with these conditions and it's not very specific.
Mm-hmm.
So I hope that answers that question. And then I see that there's also a question about what's the gene associated with metastatic prostate cancer. So going back to that slide that I showed you earlier, here we go. So that pie graph there shows you a whole wide variety of different genes associated with metastatic prostate cancer. BRCA2 is by and large the most common gene mutation that we see in men who have metastatic prostate cancer, but that's not the only one. All of those genes that are kind of listed there, some of them we know a lot about, some of them we don't know as much about, but they have been found in men with metastatic prostate cancer. A lot of those genes in that pie chart actually work together in the same DNA repair pathway that I keep referring back to. So it makes sense that those are the genes in which we find mutations in men who have metastatic prostate.
All right. Thank you so much, everyone, for participating today. Thank you so much, Shrutika, for doing another wonderful program for our participants.
All right. Thank you guys so much.
All right, everybody, have a wonderful rest of your day.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.